Hi everyone, my name is Savannah Bowman. I'm a second-year internal medicine resident at Baylor College of Medicine. Dr. Lou is my research mentor and she's a rheumatology attending at MD Anderson here in Houston, Texas. Today I'm going to be talking about inflammatory myopathies induced by aromatase inhibitor therapy. We have no conflicts of interest to disclose, and I'd like to thank Dr. William Murphy for his assistance with preparing the radiology slides. So the presentation outline today will be talking about a brief review of inflammatory myopathies. We'll discuss the association between aromatase inhibitor therapy and autoimmune disorders. We will then evaluate 3 cases of myositis associated with aromatase inhibitor therapy, and then we will talk about the hypothesized mechanisms of how aromatase inhibitor therapy can lead to aromatase inhibitor associated arthralgia and also to autoimmune conditions. So the term idiopathic inflammatory myopathies is also another term for the word myositis. These are disorders characterized by muscle weakness and muscle inflammation. The most common subgroups are dermatomyositis, polymyositis, and inclusion body myositis. The clinical features of myositis are symmetric weakness of proximal muscles with or without pain. This will commonly present as the person having difficulty walking upstairs, getting up from a chair, and then also combing their hair. The classic rashes associated with dermatomyositis are the heliotrope rash, Schall sign, and V sign, and then Gottron papules. To diagnose myositis, you can have elevated muscle enzymes. You can also use EMG and MRI, and then the gold standard is going to be a muscle biopsy. These are typical rashes that are seen in dermatomyositis. So figure 1 shows classic Schall sign. Figure 2 is Gottron's papules, and then figure 3 is the classic heliotrope rash around the eyes. A brief overview of aromatase inhibitors. So the enzyme aromatase converts androgens to estrogens. Aromatase inhibitors inhibit this reaction. They're the mainstay of therapy for postmenopausal women with estrogen receptor positive breast cancer in the adjuvant setting. The most common aromatase inhibitors that we use in patients are anastrozole, letrozole, and exemestane. Everyone knows about the common rheumatic side effects of aromatase inhibitors being bone loss leading to osteoporosis, arthralgias, and myalgias. More recently, aromatase inhibitors have been associated with the onset of autoimmune disorders. The strongest evidence exists for rheumatoid arthritis, but there are also case studies out there where aromatase inhibitors have been associated with the onset of spondyloarthropathies, systemic sclerosis, Sjogren's syndrome, cutaneous lupus, antiphospholipid syndrome, and antisynthetase syndrome. There was a large Italian population-based study in 2017 that looked at 7,533 women with breast cancer, and on aromatase inhibitor therapy, there was 113 new cases of rheumatoid arthritis. When tamoxifen was used as a reference, aromatase inhibitor therapy was associated with an increased risk of new onset rheumatoid arthritis. The first case that I'm going to be presenting today is a case about polymyositis that was associated with aromatase inhibitor therapy. So for our first patient, we have a 64-year-old African American female. She has stage 1A breast cancer, estrogen receptor and progesterone receptor positive, HER2 negative. She's status post-segmental mastectomy followed by radiation in 2016, now presenting with proximal muscle weakness. She was on anastrozole for 6 months, but this was switched to letrozole due to joint pain. She received a combined total of 2 years of aromatase inhibitor therapy prior to symptom onset. Over the past 2 months, she's been experiencing progressive proximal muscle weakness. Her physical exam is notable for 2 out of 5 proximal muscle strength in her upper and lower extremities. She underwent a round of age-appropriate cancer screening, including a PET-CT, which was negative. Her CK level was 5,976, CKMB 194, high sensitivity troponin 1,263, and her aldolase was 54. Her MRI, which we'll see on a future slide, showed diffuse symmetric mild sarcopenia in bilateral thighs and patchy enhancement throughout the muscles of the right thigh, suggestive of active myositis. The muscle biopsy of her right vastus lateralis muscle revealed necrotizing myositis. An autoimmune myositis panel showed elevated anti-signal recognition particle and then also anti-Rho52 antibody. So on this MRI on the left-hand side, you can see a T2 weighted image of the right thigh muscles showing increased T2 signal intensity in muscles of both the anterior and posterior compartments seen with the red arrows. And then on the right side is a T1 post-contrast fat-saturated image that shows matching contrast enhancement consistent with polymyositis. For her clinical course, she was treated with 60 milligrams of prednisone and IVIG for inflammatory myositis and presumed myocarditis as well. Her CK decreased to 355 and troponin to 769. Her prednisone was tapered, and once her prednisone was tapered, her CK once again increased to 1,489, and this prompted methotrexate to be added. Her CK continued to rise to 2,201, and she underwent another cycle of IVIG. Over the next 2 years, she was maintained on daily prednisone, weekly methotrexate, and monthly IVIG, and she continued to have persistent weakness and CK elevation at 250 to 650. In July 2021, she completed 5 years of aromatase inhibitor therapy. Once letrozole was stopped, 2 weeks later, her strength improved and her CK totally normalized, and she was able to be taken off of all medications for polymyositis without any additional flares. The second case that I'm going to be presenting today is a case of amyopathic dermatomyositis associated with aromatase inhibitor therapy. In this case, we have a 43-year-old female with a history of stage 1A ER-PR positive, HER2 positive invasive ductal carcinoma of the left breast, diagnosed in June of 2013. She underwent segmental mastectomy and adjuvant chemotherapy with doxorubicin and cyclophosphamide, followed by 11 cycles of paclitaxel and trastuzumab, with trastuzumab maintenance treatment for 1 more year. Anastrozole was started in June of 2014. 2.5 years after she was initiated on aromatase inhibitor therapy, she developed a progressive pruritic pink and violaceous erythema with a typical distribution on the scalp, V of the neck, shoulders, and dorsal hands. And on the dorsal hands, her rash was consistent with Gottron's papules. She experienced proximal muscle weakness, but her CK was not elevated. She had a skin biopsy which showed interface dermatitis, superficial perivascular lymphocytic inflammation, and increased interstitial mucin. Given her skin biopsy findings and also the characteristic rash, she was diagnosed with amyopathic dermatomyositis. She underwent a CT chest, abdomen, and pelvis, which was negative for malignancy. For her clinical course, she was initiated on prednisone 60 mg daily, hydroxychloroquine 200 twice a day, azathioprine 50 twice a day, and IVIG. Her rash was well controlled with this regimen, but when her prednisone was tapered from 20 to 10 mg, the rash reappeared. Over the next 2 years, she remained on hydroxychloroquine, azathioprine, and IVIG every 3 to 6 months for dermatomyositis flares. In August of 2019, she completed her aromatase inhibitor therapy. Her rash has not returned since, and now she is completely off of the above listed medications. For the third and final case, we're going to be talking about a case of fasciitis that was associated with aromatase inhibitor therapy use. In this case, we have a 54-year-old Caucasian female with a history of T3N1M0, ER-PR positive, HER2 negative, invasive lobular carcinoma of the right breast, status post modified radical mastectomy in August of 2012. Her right axillary lymph node dissection, 3 of the 39 lymph nodes were positive. In September of 2012, she underwent 12 cycles of adjuvant chemotherapy with paclitaxel, followed by fluorouracil, doxorubicin, and cyclophosphamide, and then radiation therapy. She was on tamoxifen from April of 2013 to November 2016. Her tamoxifen was then switched to anastrozole in November of 2016. 7 months after she was started on anastrozole, she developed skin and muscle tightness in her arms, legs, and torso. Her physical exam was notable for lymphedema of her right hand and arm, skin thickening of her distal upper and lower extremities, and hardening of the muscles in bilateral lower legs. She had a positive ANA of 1 to 640. The pattern was speckled. She had an elevated aldolase of 8.6, ESR 68, high sensitivity CRP of 24.9. Her anti-SCL70 and anti-centromere antibodies were negative. She had a normal CK, and her thyroid studies were normal as well. Her MRI, which we'll see on an upcoming slide, shows mild diffuse edema with enhancement and thickening of the superficial fascia of the right lower leg consistent with fasciitis. Her muscle biopsy as well was consistent with fasciitis. So on the left, we see a T2 weighted image of her right calf showing high T2 signal intensity of fascia surrounding the calf muscles. On the right-sided image, you can see T1 post-contrast fat-saturated image showing matching contrast enhancement consistent with fasciitis. This is a slide of her pathology. On the left-hand side, you can see a lot of inflammatory cells within the fascia. On the right-hand side, you can see inflammatory cells in both the epimysium and perimysium. For her clinical course, she was started on prednisone 60 mg. Methotrexate was added, but it was discontinued due to elevated LFTs. She self-discontinued the anastrozole, and while off of it, she continued to have improvement of her muscle and skin tightness. It did not completely resolve, and she remained on prednisone 10 mg. In June of 2018, she was started on another aromatase inhibitor, exemestane, and from June of 2018 to September 2019, she had progressive skin and muscle tightness in her legs, arms, and torso. She then self-discontinued the exemestane, and at her most recent follow-up visit in April of 2021, her symptoms were 90% better, and her prednisone was able to be tapered off. So now I'm going to discuss aromatase inhibitor-associated arthralgia. So arthralgia is associated with aromatase inhibitor therapy use is common. And up to 50% of women will experience some type of joint pain associated with aromatase inhibitor therapy use. There has been a criteria put forward about aromatase inhibitor associated arthralgia. There's 3 major criteria. 1, currently undergoing aromatase inhibitor therapy. 2, joint pain that has worsened or developed after starting AI therapy. And 3, joint pain that resumes upon resuming aromatase inhibitors. The minor criteria are symmetrical joint pains, hand or wrist pain, carpal tunnel syndrome, decreased grip strength, morning stiffness, and improved joint discomfort with use or exercise. The hypothesized mechanisms for aromatase inhibitor-associated arthralgia and possible mechanisms of how aromatase inhibitors can be associated with autoimmune conditions are laid out below. So there has been evidence that genetic factors that primarily affect the estrogen pathway might be linked to aromatase inhibitor-induced arthralgias. There's a single nucleotide polymorphism that encodes for the gene HSD17B2 in the estrogen pathway that's associated with higher odds of developing arthralgias associated with aromatase inhibitors. This gene encodes for the enzyme that is responsible for the oxidation of estradiol into estrone. There's also evidence that exists that possibly genetic variations in the vitamin D receptor can make people more susceptible to having joint pains associated with aromatase inhibitor therapy use. And then also high levels of estrogen may reduce inflammatory cytokine production. So then when we deprive the body of estrogen, this may lead to higher levels of inflammatory cytokines that can then lead to joint pains and possibly also autoimmune conditions. The clinical significance of these 3 cases is that if a patient develops an autoimmune condition, or specifically in these 3 cases an inflammatory myopathy while taking an aromatase inhibitor, it should be considered that the aromatase inhibitor might be the cause, and the medication should be discontinued if able. I appreciate everyone taking the time to listen to my presentation, and I will now accept any questions.